So the first question here, child is unable to stand suddenly. On examination, he is normal except for ataxia. CT brain normal. So what is your diagnosis? If here the clue here is CT brain is normal. So in brain abscess, we don't see CT brain normal. And he is normal except for ataxia. So it is mainly going for acute cerebellar ataxia, because what else you see in, we have to negate other things now. For example, in Friedreich's ataxia, apart from ataxia, what else you see? Yes. So we will see some other features also. That means they are not normal except for ataxia. In brain
Yeah, there will be the Benke's positive from birth.
Yeah, what you said?
The Benke's will be positive in Frederick ataxia, and here they mention he is normal.
Yeah, he's normal except for ataxia. And also the CT brain is normal. That mean brain abscess, definitely we'll see the abscess in the CT brain, right? So CT brain will not be normal. So these two options is gone. In ataxia telangiectasia, the child, you will see telangiectasia everywhere and repeated infections. So most probably this is acute cerebellar ataxia. So when we choose the answer, we should also search for negation. Why this is not an option? Why this is not an option? Okay. This is the second thing here, important point, meningitis. Whenever there is meningitis due to H influenza, you have to consider dexamethasone. This is very important. A question will come on this. Okay, and whenever there is an hydrocephalus infected shunt, the organism you have to suspect is Staph epidermidis. Meningitis plus H influenza considered to give dexamethasone, and any infected shunt in cases of hydrocephalus is, you have to consider organism Staph epidermidis. Next is myelination. At what age the myelination starts? So the option is 0 to 6 months. That means it starts after birth, right? Anyone has any comments on this?
No comment.
Okay, so we have to remember, but if we have doubt, we have to go back and check, because here option is 22 weeks of birth, 22 weeks of gestation, 22 weeks to birth, 22 weeks of gestation, and 12 months. I don't think 12 months will be there. And mostly it starts after the birth. So 0 to 6 months is the correct answer. Myelination. So brain myelination, then when it becomes amplified, means it becomes more, it starts at the age of 0 to 6 months, but it becomes more between 6 to 12 months. So almost by 1 year, most of the myelination would have been completed. Okay, but better we go back and check this again just to be sure, because whatever they have marked in blue, as per this book, it is supposed to be correct. But if we want, we check, and in the next class, if there is any difference, we can discuss. Next is how to recognize facial nerve during parotid operation. So we all know that facial nerve will come out of the mastoid process. Stylomastoid foramen. It will come out of the stylomastoid foramen. So we will check the mastoid process and we will check the stylomastoid foramen. So they will ask you this question. How do you recognize facial nerve during parotid operation? You will first recognize stylomastoid foramen. How do you do that? For that, you will check the mastoid process. And as the nerve leaves, we will check the stylomastoid foramen. This is also one of the questions. Better we see one picture. I will check if I get. I will post here before we finish the meeting. We'll have this picture of stylomastoid foramen. Just 1 minute. Next is holocranial headache in a child continues for 6 to 8 hours per day. So it will be holocranial all over the cranium, 6 to 8 hours per day. Most probably they are telling tension headache. This will be a tension headache. If it is from raised ICP, it should also be associated with early morning headache with vomitings and all. Okay, they have just told here holocranial headache for around 6 to 8 hours per day, most probably going with tension headache. Next, there is the modified Glasgow Coma Scale for infants used to grade. What is its purpose? Is to use to grade coma in infant. But we will go back and check what is this modified Glasgow Coma Scale, and I will post you in the group now. This is the modified Glasgow Coma Scale for infants and children. The same thing what we usually used to see. Eye opening, whether it is spontaneous or to speech or to pain only and no response. Next is best verbal response. That is for infant, we have to check whether he coos or babbles. This will be 5. Irritable cries will be 4. Cries to pain, moans to pain, no response. This is for best verbal response. For eye opening, spontaneous, he opens to speech, to pain only, no response. Then best motor response is moves spontaneously or purposefully, withdraws to touch. This is 5. Withdraws in response to pain, 4. Abnormal flexion posture to pain, 3. Abnormal extension posture to pain, 2. No response. It's almost same, but you have to apply it to the infant. Like for example, big child will obey your command, but for the infant you will see spontaneous motion, how he's moving the legs and the hands or no. The big children will be oriented and will answer to your questions, verbal response. But here you have to check whether the infant is coos or babbles, some changes only. But we should know why this is used. The question here is modified Glasgow coma scales for infant used to grade of coma in infant. Just you will write, you will check the how comatose is the infant or whatever the other options. He has not given the other options. You have to check and write, but we should know what exactly is this modified Glasgow coma scale for infants. Next is best description of rheumatic chorea. How do you describe the rheumatic chorea? So the movement is rapid, jerky, non-rhythmic, involuntary movement. This is the description. So we have to go back and check an video for the chorea. So best description for rheumatic chorea is rapid, jerky, non-rhythmic, involuntary movement. Chorea. Next is, see here, you should know what is the definition of chorea. Definitely, chorea is an involuntary movement. I don't know, static, why he's telling static, I don't know. We will check it. Involuntary, irregular, sudden, jerky, semi-purposeful movements involving mainly the face, trunk, and limbs, aggravated by emotional stress and disappear during sleep with hypotonia, except in Huntington's chorea. This is very important. They can ask you the question. In Huntington's chorea, you will have hypertonia. Otherwise, all in general, in chorea, there will be hypotonia. And see, this word non-rhythmic is very important here. They will not show a particular rhythmic movement for you. It will be irregular. This is what is the correlation here. Non-rhythmic here means the movement will be irregular. One time it might be like this, the another time it might be in a different way. That is why it is irregular and non-rhythmic. Not the same type of movement you will not get. So chorea is a involuntary, irregular, sudden, jerky, semi-purposeful movements involving, you will mainly see in the face, trunk, and limbs. They are aggravated sometimes by emotional stress and disappear during sleep. And they are mostly, the child will be hypotonic, but exception is the Huntington's chorea. You will see hypertonia. So anyone wants to comment on chorea can go ahead. Is it
No,
clear?
ma'am, thank you. It's clear.
Okay. So if you see, it is involuntary and it is not going in one rhythm, not in the same way. It is irregular. You have to apply all the points what we see. Involuntary, irregular, involving the limbs and the trunk and the face. So what's the question on chorea? Chorea can present with all of the following, except they'll give you options. You have to check, you have to tick akinesia, means they will not present like motionless. Akinesia means no motion, right? They will not present like motionless. Usually there will be some movement. There is always movement. So it's an involuntary movement, which will be irregular, sudden, jerky, involving the face, trunk, and limbs. So akinesia will not be a characteristic of chorea. Next, boy, 10 months old boy, mother noticed left eye deviated to one side 1 month ago. That means when he was 9 months old, she noticed that his left eye is deviated to one side. What to do? So whenever you see a patient with squint, you will not directly do CT brain or MRI brain or anything. If the child age is more than 3 months, if less than 3 months, you will ask the parent, you will reassure the parents to wait till 3 months, because the development of the muscles of the eyes will take some time. So the squint in the early months can be due to the weakness in the muscles of the eyes. So you will wait till 3 months. You will reassure. But if more than 3 months still the squint is persistent, your option will be refer to ophthalmologist. We will not do any CT brain or MRI brain or anything. We'll just refer to ophthalmologist. So this is the answer for this. Next, what is the best investigation for neuronal migration? The best investigation for neuronal migration is MRI. Okay. Next, you have a child, he is convulsion. He is in convulsion. He has tonic-clonic seizures and it is fasting. It is lasting for 40 minutes and temperature is 38. So the option here is febrile convulsion. I don't think the simple febrile convulsion will last for 40 minutes like this, like a status epilepticus. Usually febrile convulsion is for a short, brief period of time, and it will be associated with high-grade fever, and it will get spontaneously aborted. So this option will not fit for this. Even though the temperature is 38, we cannot categorize it into simple febrile convulsion. So now there are two options, idiopathic and symptomatic. I don't know why they are telling symptomatic. Maybe this is associated with 38 temperature. Maybe this is from meningitis or encephalitis or something like this, which is presenting to you with a symptom of a fever. So the option here is symptomatic status epilepticus. Okay. Next is case scenario of seizures. There is history of URTI last 2 days plus fever. Best treatment, lorazepam. This is, they are talking about febrile convulsion here. Child had URTI, may be presented with high-grade fever and with seizure. So the most common cause of status epilepticus in children is febrile seizure. Treatment, control temperature, lorazepam or midazolam or diazepam. What is available is indicated if seizure lasts more than 5 minutes. Status, duration is 20 to 30 minutes or serial or frequent without regaining consciousness. But nowadays, now recently, even 5 minutes, if the convulsion, if the seizure lasts for more than 5 minutes, then it is considered as status. Okay. So the most common cause of status epilepticus in children, they are telling sometimes the febrile seizures can present as status epilepticus. If the seizure lasts, we will consider as more than 5 minutes because new guidelines, any seizure more than 5 minutes is status epilepticus. More than 5 minutes. And they are, or another definition is if the seizures are frequent without complete regaining of consciousness. Okay. So what is the treatment you give for this status epilepticus associated with fever? Is the first thing is you will control the temperature. The second thing is you will if the child is seizing, you will not leave him to in fits. So you will control either by giving, you have rectal diazepam or buccal midazolam or IV lorazepam, whatever is available, you will give. He is telling when you will consider, if indicated, if seizure lasts more than 5 minutes. Is it clear, or anyone has comments about this febrile convulsion?
No, it's clear.
Okay. So there will be a simple question for us. If it's a febrile convulsion and the child is in when they arrive to you, they are convulsing, definitely you will consider some anticonvulsant depending upon whatever option they've asked, like diazepam, midazolam, or lorazepam. And one of the important treatment is control the temperature. And if the seizure is lasting for more than 5 minutes, you'll definitely consider some medication. And the definition of status is more than, if the seizure lasts for more than 5 minutes, or if the seizures are frequent without regaining the consciousness. This is very important. Frequent without regaining the consciousness. Okay, next question. Patient with status epilepticus, which type is not common in pediatrics? I don't know what is this cryptogenic. Prolonged fever, just now we read it is common, because here he wrote, you see, most common cause of status epilepticus in children is febrile seizure. So prolonged fever can be idiopathic also. I don't know what is cryptogenic. If anyone knows, tell, or we will check, no problem. Okay, just wait. Okay. So here he has told cryptogenic is referred to new onset refractory status epilepticus. Cryptogenic is a type of refractory status epilepticus in a patient without active epilepsy and without clear acute or active structural, toxic, or metabolic cause. Here they are telling it cryptogenic means it should be refractory. That means you're giving what do you mean by refractory? Refractory means you're giving medications, but the patient is not responding to your medications. This is refractory, right? So it's cryptogenic is a type of idiopathic only, but it will be refractory status epilepticus in a patient without active epilepsy. He is not a known case of epilepsy and without clear or active structural, toxic, or metabolic cause. There is no clear cause, and the patient is in refractory status epilepticus. This is cryptogenic. Okay, I will share the screenshot in the group.